I promise it will be a very exciting and interesting session as it deals with stigma in healthcare, and you'll be surprised to see how much minorities, how much people in general are stigmatized within the confines of a healthcare setting. So this panel will highlight the ways that minorities and vulnerable groups, and they can be vulnerable by sexual orientation, vulnerable by income, vulnerable by where they come from, and how they are subject to stigmatization and harassment socially and structurally. And before I introduce my colleagues, I would just like to share with you a couple of slides as a background for this session. One of the probably most shocking news that came out of research in Lebanon, and hopefully will be reflected on this session, is a piece of work we've done with Helm and Joe at that time, showing that, if you look at this slide, this is the opinion and attitude of physicians practicing in Lebanon regarding homosexuality. Okay? And it looks like the higher percentage of those doctors are not aware of a relative or a friend who is a homosexual. And the most worrisome thing, if you look at this, the definition of homosexuality is a disease that needs medical assistance, and also it needs a psychological counseling. The majority of the physicians have answered that homosexuality is a disease that deserves either medical attention or psychological attention in around 73% of the people. And at the same time, almost none have received any training in the medical school on the issue of homosexuality. Thanks God, lately, over the past 2 years, while doing the OSCE, which is an on-site exam for medical students at AUBMC, whenever the model, they are asking her about sexual behavior, they immediately jump to ask her if she is heterosexual or bisexual or homosexual. And that reflects a growing sensitivity to sexual orientation of people, but that is still within the confines of AUBMC. Based on that, as Dr. Randoul, my friend, mentioned this morning, we did some work, and hopefully this work will add up to the ongoing work, whether at AUB or outside, regarding looking at the training doctors in around 8 hospitals on youth-friendly sexual and reproductive health services, and that was done by the Youth Sexual Reproductive Health Project at the Faculty of Health Science at AUB. And at the same time, we conducted 2 years ago the first LGBT course for healthcare providers, again at AUB. Last year, the last week, there was the LGBT also week, the second event in that regard, and it was a successful event. And the third one also, we continue every year to conduct a course for healthcare providers, again, on female sexual dysfunction and female sexuality that's based on sexual rights and human rights. And as I said, it goes on with many colleagues in many universities working with the perspective of equality, non-judgmental, confidential services, and ethical framework for these services. I'm happy to invite the first speaker in this panel, our colleague and friend, Ms. Sara Abou Zaki. You can see Sara is popular. Sara is the project coordinator of Marsa Sexual Health Center. She has also been a graduate of the School of the Faculty of Health Science with a Master's in Public Health, and she spent some time in AUBMC working on sensitizing people to the issues, sexual issues and sexual health of minorities, before ending up as a project coordinator in Marsa, and she will be talking on sexual health of men having sex with men. And Sara, you have 10 minutes.
Thank you, Dr. Kab, for your introduction. So, as mentioned, I'll be discussing a summary, actually, of our findings for research we have done on the sexual health of men who have sex in Lebanon. So, a brief background to begin with. Why is it important to explore the sexual health of men who have sex with men in Lebanon? Well, even though it has been established that sexual health is an essential component of our health and our well-being, however, excuse me, just give me a second. However, there are a lot of barriers to sexual health in Lebanon, and some individuals are even more vulnerable to these barriers, specifically individuals who are, for example, as men who have sex with men. And we're going to explore the reasons why they are more vulnerable to these barriers in a second. So I guess the most obvious barrier to sexual health in Lebanon would be, and also happens to be the title of our panel, it would be stigma. Specifically, stigma associated with sex outside of marriage. So individuals who are sexually active but not married are reluctant to seek sexual health services because they are afraid of being stigmatized. Well, the case is even more critical for men who have sex with men, because they are not only afraid of being stigmatized because they're sexually active, but also based on their sexual practices. I guess a bunch of you already know that there's a penal code in Lebanon that criminalizes sex that is quote-unquote against nature, and this is commonly used against men who have sex with men, and of course it contributes to further stigma and discrimination against them. And this hinders prevention and early detection of STI, because men who have sex with men are not only reluctant to seek sexual health services because they're afraid of being stigmatized, but also because they're afraid of being criminalized. Another important barrier to sexual health, one that we cannot mention enough, is the lack of sexual health education in schools and universities. This is a very important barrier because it means that there's a lack of accessible information about sexual health topics, such as prevention of sexually transmitted infections, treatment, contraception, and different kinds of topics. Moving on, there is also a very important barrier, the fact that a lot of healthcare providers in Lebanon do not have the adequate skills to cater to patients' sexual health. I'm going to cite here an article that was just actually mentioned by Dr. Lecoq. It's a study done by an organization called HELM and Dr. Lecoq back in 2009, and found that around 50% of the physicians in the sample, the study, refused to tend to LGBT patients. And this is a very clear example of how discrimination and stigma can come in the way of an individual accessing very much needed healthcare, of course. Also, the study found that a lot of these physicians did not have relevant knowledge on the management of sexually transmitted infections among key populations, such as men who have sex with men. Another very important reason why we decided to go through with the study on sexual health of MSM is because we found very little literature on the topic in Lebanon specifically. In fact, only a few articles, some of which are cited on this slide, actually deal with the topic of sexual health of MSM. Also, if you've noticed that the sample size is rather small, and they even used something we call convenient sampling, respondent-driven sampling, and this causes some sort of concern because the results are not usually generalizable to the population because of the size of the sample and because they're usually from similar backgrounds, so the results are not very representative of the general population. And also there was little exploration of sexual practices and behaviors of MSM and any possible association between the two. So the aim of our study was, of course, to evaluate rates of different sexually transmitted infections among a sample of MSM who had come to Marsa over 2 years. And it was also to explore different common sexual practices and risky behaviors of the sample, and to evaluate any possible associations between risky behaviors and any of the other indicators in our analysis. So we're moving on to methods. So at Marsa, there are a number of services. One of them is the voluntary counseling and testing services. During this service, an individual receives information on sexually transmitted infection and different key topics of sexual health from a sexual health educator. Meanwhile, the sexual health educator administers a detailed questionnaire that have the different indicators that we also happen to use in our analysis, and we'll be discussing them in later slides. At the end of the session, the individual has the choice to do the rapid test for HIV, hepatitis B and C, and syphilis, if they choose to, of course. Similarly, we have another type of service, and it's the medical consultation. These are performed by medical practitioners who also administer the detailed questionnaire. And the only difference is that during the medical consultation, individuals can screen for other STIs, such as gonorrhea, chlamydia, HPV, and other. So here is some of our collected information. These are the indicators we have collected from our questionnaires, some basic demographic indicators, and some that are related to substance use, notably, of course, would be the recreational drug use, as well as cigarette smoking and alcohol consumption. Here are some indicators on sexual practices and risky exposure. So we asked about condom use with partners, lubricant use during penetrative sex, and number of sexual partners in the past 3 months. We also asked about their last oral sex exposure and last anal sex exposure. This slide shows our outcome variables. So the STI status are our outcome variables, as well as condom use behavior and recreational drug use behavior. You can see also a summary of our statistical methods. So moving on to our results. First of all, with our demographic characteristics of our sample. So out of 3,145 individuals who have come to Marsa in the span of 2 years, 1,351 were men who have sex with men, and they constitute our sample, basically. And it's important to note here that although this can be considered somehow as a convenient sampling as well, because individuals come to Marsa to seek sexual health services. However, the difference is that our sample is actually very diversified. It comes from all different age groups, from different backgrounds and different geographic areas in Lebanon. That adds some variability to our analysis. And also the relative size of our sample is relatively bigger than that of the local literature. The mean age of our sample is 28. It ranges between 15 to 69 years. Here you find the level of education and employment status of our sample. The majority are university students or received university education. As for the occupation, it's pretty diverse. We have approximately 7% that are unemployed, 29% reported being students, and the rest are, as you can see. So we asked our sample why they came to Marsa, why are they getting tested, and we found that 57% stated that it is because they had condom sex at some point in the past. Therefore, we can say that most of our samples are actually at risk. And also we have 2% who stated that they believe they have symptoms of sexually transmitted infection, or that they believe their partner also has a sexually transmitted infection. So these individuals are at risk, as we can see. We always make it a point to ask individuals about their sources of sexual health education. And as you can see, the results here actually mirror what we said in the first couple of slides. Only approximately 9% stated that they received their sexual health education from either a school or university. And as you can see, 12% stated that they received their sexual education just from Marsa, meaning that before they have come to Marsa, they had no sexual health education. Various sources include a combination of different sources, some that can be reliable and some that are unreliable sources, such as internet, including pornography, or even peers or sex partners. When we assessed the answers of our sample for the question where we asked them if they use recreational drugs, we were surprised to find that 29% of our sample reported using recreational drugs. And this is a very critical finding because use of recreational drug can affect their condom use behavior, an individual's condom use behavior, and can also affect their ability to give and receive consent before a sexual encounter, which is very critical, and we'll be referring to this in a later slide as well. So 50% of our sample reported smoking cigarettes. Also 8% said they consumed alcohol. It's important to note that there was no correlation between alcohol consumption and recreational drug use. Moving on to sexual practices. So when asked about the number of sexual partners in the past 3 months, Only 19% of our sample stated they had 0 to 1 partner in the past 3 months. The vast majority has had multiple partners in the past 3 months. Then we asked, one of the questions was about condom use behavior with different kinds of partners. So we asked about their condom use behavior with a steady partner, which is a monogamous partner, also with a regular partner, which is a frequent partner but not a monogamous partner, and of course a casual partner, which is a one-time partner. And I think the most notable result here is that when asked about their condom use with casual partners, around 50% stated that they do not consistently use a condom with a casual partner. Therefore, they are at a higher risk of contracting sexually transmitted infections. We also asked about the use of lubricant. We always encourage individuals and about the importance of using water-based lubricants because it decreases the risk of a condom breaking or of getting injuries as well. However, even with that, the majority of the sample say that they do not consistently use lubricants during penetrative sex, of course. When asked about the reported reasons for not using a condom, here you can see a various number of answers. I'd like to note, of course, 13% stated that they were under the influence of a substance. So as we had said before, use of substance can hinder a person's condom use behavior and put them at risk of contracting sexually transmitted infection. Also, 13% stated that they had misinformation about condom use, so either they did not know how to properly use a condom or when to use it. So these are preventable if we had a comprehensive sexual health education available to everyone. So 24% stated that they were caught in the heat of the moment, so probably did not have a condom on them. And this is where it's very important to promote condom use and to make it more habitual so that people are more likely to hold one with them and use them, therefore. So the majority of our sample reported that their last anal sex exposure was risky, and by risky we mean condomless or with the condom misuse. Similarly, in oral sex exposure, the majority, around 90%, stated that their last performed oral sex exposure was risky as well. The same for approximately the same, around 90% also reported that their last received oral sex exposure was also risky. And this is very important because oral sex puts individuals at the risk of exposure to different STIs such as gonorrhea, chlamydia, and even HIV if it's not protected. We went on to determine determinants of risky condom use behavior using a regression model. All these results are statistically significant. So we had those who reported only having a school-level education were 2 times more likely to have a risky condom use behavior compared to those who reported a university-level education. Those who reported getting their sexual health education from unreliable sources were 1.7 times more likely to have a risky condom use behavior with casual partners compared to those who reported getting their sexual health education from reliable sources. So here again, we come to the point of how important it is to have reliable and accurate information on sexual health available to everyone. On a similar note, also those who reported having the sexual health education from reliable and unreliable sources were still more likely to have a risky condom use behavior when compared to those who received sexual health education from reliable sources. So we also tried to assess the determinants of drug use behavior using another model. And here are the results. We found that those who reported a school-level education were actually less likely to use recreational drugs when compared with those who reported a university-level education. When we tried to understand this result, we thought that maybe perhaps in universities, individuals are more exposed to recreational drug use, and it could be something they can pick up from their peers. On a similar note, students were significantly more likely also to use recreational drugs compared to those who were employed. This also echoes what we said for the first result.
0 minutes. 2 more.
I'll be really quick.
They accuse me of harassment.
Okay, I'm going to go through these quickly. So those who reported having multiple partners in the past 3 months were also at a significantly higher odds of using recreational drugs compared to those who only reported having 1 partner, 0 to 1 partner in the past 3 months. Also notably, those who reported smoking cigarettes were 4 times more likely to use recreational drugs compared to those who don't smoke. Last part of also I promise. These are the prevalence rates. So 70 individuals in our sample tested positive for HIV. That accounts to 5.4% of our sample. This is higher than the prevalence rates reported in local literature. Here are some prevalence rates for other STIs that are also tested during the voluntary counseling and testing session. Notably, also syphilis accounts for 3% of our sample, which is higher than rates reported outside of Lebanon. For a subset of our beneficiaries who attended the medical consultations, we found that 20.8% of them, close to 21%, had symptoms indicative of gonorrhea and candida. 44.5% had warts, which is an indication of an HPV infection, and around 2.7 had pubic lice. When we tried to assess different possible factors for HIV, we found that age was not significantly correlated with HIV status. Neither was the level of education. It's not a determinant of HIV status. And when we assessed the different reasons for not using a condom, specifically for HIV positive individuals, it was kind of mirroring that for the entire sample. Most notably, I guess, would be that some 23% actually did not use a condom because they had misinformation about condom use. But this was preventable had it been that we had accessible information. And 7.5 reported that they were under the influence of a substance. So in conclusion, that's it. So just to sum it up, so based on these results, we believe that we really need to increase our efforts targeting the MSM community, specifically to improve their knowledge on sexually transmitted infections and how to decrease the chances of contracting them. Also on behavior, that's very important, specifically condom use behavior and recreational drug use behavior. We also believe we need to work for further sexual health promotion on many levels, whether direct outreach with members of the community or through providing more and more health promotion material. We really need to rally for a more inclusive healthcare system, void of any discrimination, so that we can allow individuals to easily access healthcare that they really need. And in that way, we can promote routine testing, which is very important to catch STIs early on. We need to maintain efforts, of course, for further exploration of different determinants of sexual health among MSM and the general population, and other subpopulations, of course. We need to target schools and universities to lobby for the incorporation of a comprehensive sexual health education for the youth in Lebanon. And we need to target youth to encourage and promote, of course, condom use, as well as highlight the effects of recreational drug use, most notably on their condom use behavior and their ability to give and receive consent. And that's about it.
Thank you very much for this very interesting, and of course we deserve more time, but we're limited by 10 minutes, sorry. But I'm sure you'll have a lot of questions at the end of the session. Our next speaker is my dear friend and colleague, Professor Jihad Makhoul. She is a professor of public health at the Faculty of Health Sciences at AUB, and she will be presenting on the physicians' views about female surgeons. Would you like to operate it under a female surgeon?
What if need
Brain surgery.
Yeah,
I understand.
I think I might need.
Let's hear more about it.
Thank you.
And again, you have 10 minutes, not like Sara.
All right. Thank you very much. Good afternoon, everyone. I need to actually don't get the clock ticking because I need to open my presentation. Where is it? Ah, here it is. I got it. Come on. Okay. All right, here we go. This is today we're going to talk about physicians' views of women surgeons. How, in theory, things differ from practice. Just to highlight the research team, first of all, some of them are here in the audience. There are others who also helped in transcriptions, but basically Dr. Spaiti is here, and the list of wonderful ladies were doing interviews and doing much of the field work and most of the analysis with me. Generally speaking, if you look historically, surgeons have been women for a very long time. And the first woman was actually a queen from Babylon. But since the 14th century, women as surgeons have started to feel some oppression, specifically when there was a ban from entering the medical schools in general. But women fought their way back to the 19th century. However, currently, the situation isn't any better. Women are still being excluded. Even though there is a big influx of women coming into medical schools, however, only 10% of them make it to surgery as a career. So, and there are a number of reasons behind this, because studies have shown that there has been some sort of discrimination, harassment, and isolation from the administratively, but also at the workplace level. And there was also the problem of balancing work and family. So we're interested in understanding what's happening now in our parts of the world, in the Arab region, in a patriarchal society. Not a lot is understood about what's happening in terms of how women as surgeons are being, their perspectives and their issues. Now this is interesting because this is very important for us in our parts of the world because of the patriarchal nature of society. And recently there's been a study that points to the adverse experiences of women in the Arab region in all kinds of workplaces. So there's not a lot done about how society, specifically the medical profession, looks at women as surgeons in general. In the Arab world, it's really absent. This is very important because it has a lot of implications on the surgeons in general. It has a lot of implications on the quality of care that the physicians are providing, but it also has implications for career options and medical schools themselves. So we were interested to fill this gap in literature, and we were interested to explore the perceptions of physicians who are currently practicing in a few hospitals in the Greater Beirut area. So we chose a qualitative research methodology that included interviews with physicians, practicing physicians, and from 3 sites of Beirut because of the various backgrounds of these areas. So we recorded the interviews, coded them, and did thematic analysis. So most of the interviews, all of the interviews were done by trained research assistants who were very well versed in qualitative research, and we analyzed the data as they came. We did grand rounds announcements at these sites to be able to capture those who were interested, and then we did interviews with them. We asked them questions, very open-ended questions, very inviting questions, for them to explain to our research assistants, to us, what their views are. So questions about, a little bit about the work, what is a good surgeon in general, how would a woman fit into these strengths and weaknesses of female surgeons, your perspectives, but also perspectives of people around you and what you think, society is also thinking through their patients. And at the end, there was a question about what do you think needs to be done to improve the situation. So then our study participants were basically 26 practicing physicians, 18 men and 8 women, in different specialties, interventional and non-interventional specialties from these 3 research sites. So as you can see, there's a variety of level of experience between less than 5 years to plus 15 years. So the majority, as you can see, are from the 15 plus years. So we did have those who were just here 2 years ago, and those who've been practicing for 30 plus years. And they have different exposures and backgrounds, as you can see, other than Lebanon. What did we find? Well, according to the participants, a good surgeon is someone who is professionally capable, someone who has the competence, someone who can provide a good job, the care aspect, the health care, but also someone who is caring. There's a difference between care and caring. The caring is very much the interaction with the physician and with the patients and their families. It's someone who's able to provide comfort when needed. As a person, also, these are a number of recurring characteristics that our participants thought have to be there for a person to be a good surgeon in general. Which was interesting is that no one actually came to the point to explain that women are, so gender issues are not related to being a good surgeon. So no one said a good surgeon is usually a man or a good surgeon is usually a woman. So these are just some quotes, for example, that we took from the interviews. So pre-post operative care, little complications, but also at the end, patients' needs humane, patient-centered, not based on financial gain. So what about women as good surgeons? Yes, they're great because they have financial skills, they're capable in specific areas that require accuracy. They have good interpersonal traits, and they're very important because they are delicate and gentle, meticulous and compassionate, and they can multitask. These are just some examples of quotes. Hands are small, better communication skills, strengths because of their emotions. So theoretically speaking, women are as capable as men to be good surgeons because they have the competence and the physical strength. So women can be strong and weak, and men can be strong and weak as well. This is a very interesting quote. They are welcome. Ahla wa sahla, no problem. Welcome to, we can read it as welcome to a man's world. And these are just some quotes as well. Surgery is a skill, and gender has no significance. Both have weaknesses and strengths. So it's interesting to see in theory there is no problem, there is no difference between a good surgeon, whether he is a man or she is a woman. However, in practice, we can see some differences in these views. Biologically, women may be disadvantaged because of their reproductive roles and their limitations related to their emotions, and physically because they are seen to be less capable and have less strength than men surgeons. This is attributed to compulsive behavior, one of our participants said. Also, in practice, socially, they are torn because they have other responsibilities from home and to society. So their family obligations, gender division of labor, societal pressure is very much forcing them to withstand this pressure because society refuses them, and they need to prove themselves even more than men. So they have additional priorities. So then, when it comes to colleagues' views, it seemed like they were divided among those who accept, those who are reluctant to accept, and who prefer men over women as surgeons. In terms of lay views, they felt that their patients also, and people around them in society, would not really accept women as surgeons because the lack of confidence, the lack of physical strength, and because it is a conservative society and women have to prove themselves, so they are guilty until proven innocent, sort of. So these are just some quotes, and it's interesting to see that even the men were saying the same thing about, the men physicians were saying the same thing that the that their patients were saying. So it looks like that men are part of this culture. They are affected as individuals in this culture about views of women. So it turns out that there is no major difference in physicians in terms of their views of women. Capabilities of women as surgeons, readiness to collaborate, all these, there is no difference. Not affected by years of experience, not affected by where they study or where they practice, regardless of gender, regardless of training or specialty. So they had a number of suggestions on what needs to be done, and there are 4 levels. We grouped those into 4 levels. At the level of society, something has to be done. We need to start bringing up children with a gender-sensitive perspective. We need to increase awareness, but this is not easy because it requires time. We need to work to prove to people that women are capable. These are just some quotes. At the work site, there's also things that need to be done. The work site itself, the hospital, the healthcare setting, needs to create opportunities for women to become role models for others, and increasing the women's support and referring patients to them by the MDs who are men, because they are more trusted in society. So then, also at the medical schools, there's a big emphasis on gender equality, mentorship system, and revision of curricula to include a gender sensitivity and enhancing social inclusion for women rather than exclusion earlier on in the medical school. Last but not least, women have to do something about it as well. So it's up to women to come in. It's not just about society. Women have to work harder than men to prove themselves because of the highly competitive culture within which they work. And they need to choose specialties where they can attract patients to prove themselves to begin with. Thank you very much.
Not easy to have a male moderator for 5 female speakers. Anything I say will be taken like, they have to keep time. Thank you very much, Dr. Mahmoud, for a very interesting, enlightening presentation. And now I'm going to invite colleague and friend, Dr. Umayyam Sharafieh. Dr. Sharafieh, she is a clinical professor of family medicine, and also she has a subspecialty in infectious disease, and she'll be talking about stigma in healthcare, which is the core title of this presentation. We have 11 minutes.
Good afternoon. First, I would like to thank the organizing committee for inviting me to this very important forum. I especially Dr. Charlotte de Garon, who is also a dear person to me. So I will be talking during this 10 minutes about stigma. How do we encounter stigma, and what are the consequences of stigma, and how to reduce stigma and discrimination in our daily practice. So lessons from history. Stigma is not something new in medicine. It goes back to old times, even to the medieval period, when they panicked when leprosy came out. And they used to label the patients who had leprosy, the low class, the immoral, and the people who should be quarantined, and they were stigmatized. And unfortunately and strikingly, at each stage in history, we have one stigmatizing constant theme. Whenever we have an outbreak of any infectious disease, we always stigmatize a group of people, like they are, for example, the immigrants, or they are the low socioeconomic, or they are the we label them some labels and we put them out of the society, and we have to quarantine them, let's say, to protect the rest. And several examples in this respect. For example, when in the USA they had the first emerging polio epidemics, it hit the rich and the poor, but the officials insist, the public officials, that it was due to dirt and it was due to poor environment. And again, when outbreaks of cholera and typhus in 1892 came up, again they were blamed to the immigrants who were coming, and they stigmatized not only the immigrants who were coming, the whole group of immigrants who was moving to the US, and they were labeled again with names like they are the low socioeconomic, they are the outsiders, they are the people that are going to infect us. And until 2009, HIV positive persons were not allowed to enter to USA, and this is also a stigma. And even in some states, I think till 2014, there were people, HIV prisoners were put in other places than the HIV negative prisoners, and they have to wear something to say that they are HIV positive. So stigma is present, and it's always, it seems it's still there, and we have to do something about it. And I will start with, I'm sure you have been exposed to this definition, but let me review with you. This is Signs and Stigma Discrimination. So stigma refers to unfavorable attitudes and beliefs directed toward someone or something, and discrimination is the treatment of an individual or group with partiality and prejudice. Stigmatization reflects attitudes, discrimination is a behavior. And discrimination as a way of expressing it's either on purpose or sometimes not on purpose, stigmatizing thoughts. And in medicine, we have documentation about associations with some diseases, with some disfiguring diseases and curable infectious diseases, with syphilis, which patients are stigmatized, HIV, tuberculosis, leprosy, mental illness. All of these are diseases that can stigmatize patients. And the conditions associated with stigma in medicine that we also see are poverty and economic dependence, experience of violence we encounter a lot, negative attitudes towards females and racial differences, limited power many women have over their sexual and reproductive lives, and lack of influence in decision making. And these are social realities that have an adverse impact on women's health. Diseases that are stigmatized, and they are top list of a long list, are the AIDS, the venereal diseases, leprosy, skin diseases like psoriasis, and mental problems. And I will start with a case and walk you along this case. It's a real unfortunate patient who came to my clinic. And we will go through all the dilemma and the problems that this patient went through. The name is not original, it's something I created just for to be confidential. Anyway, Lina is a 22-year-old student. They presented to the clinic with symptoms of, not symptoms, she was referred because of bad performance and failure in her entire courses. She failed all her courses. Well, after a long interview with this student, she was diagnosed with severe depression. She was started on treatment and referred for psychotherapy, and we kept following her up. And on further follow-up, she reported history of rape, and she suffered bad feelings that she had to hide because of social fear. She was frightened that she could have a sexually transmitted infection. She was unable to get rid of the traumatizing feelings and events. Her family, who noted a change in her behavior, accused her of drug abuse, as she decided not to inform them. Her teachers were not supportive. And when I asked her, why did you leave yourself suffering till this time? She said, fear of being stigmatized and labeled. I'm not sure how I will be handled, and my problem will be handled in the healthcare system. Will my note in your chart be confidential? Who will see my chart? Is my father coming to your clinic also? Will you tell him? How are the nurses going to deal with me? Can you tell me? And there were a lot of questions coming up. And what happened to this student is that the delay in the stigma affects prevention, treatment, care, and behavior. And she returned seeking medical care. She was not tested and screened after the rape. She was denied the prophylactic treatment that she could have benefited from after the rape. She avoided disclosure. She had depression. The stigma negatively impacted her quality of life. And on top, her family, there was a violation of human rights because her family were not supportive. And her family came to the clinic saying that I'm concealing information. She's an addict and I'm also siding with her. And definitely because we agreed with the student not to, for confidentiality, and she didn't want to inform her parents, I have to respect this. She was subject to verbal abuse by her family, and she experienced loss of dignity, and her friends were not, also she lost some of her friends, and she was isolated. So the stigma attributes, there are 3 stigma attributes. The first one is the internalized stigma. Internalized stigma is the extent to which people endorse negative beliefs and feelings associated with the stigmatized attribute and apply them to themselves. For example, they would ask how much they feel shame, guilt, and diminished self-worth. So when I asked her, how do you feel? She said, I feel very bad, I feel guilt, I feel shame, and I worth nothing. So she had the internalized stigma. And then there is the second stigma, the experienced stigma, which is the extent to which people perceive they have experienced stereotyping and discrimination, and it's the experience of untreatment by others. And she said, how are others treating you? She said, I'm not treated at all well. My friends are left me, my family is not supportive, and when I come to the clinic, I'm afraid that someone might know what I have, and I also will be handled. She was afraid of this. And these 2 stigma, the internalized and the experienced stigma, led to an anticipated stigma, which is a stigma how one would think that people would treat him in the future. Extent to which people expect to experience stereotyping, prejudice, and discrimination directed at them from others. So she said, because she internalized the stigma and she experienced the stigma, she said, most probably I will not be treated or handled adequately in the future. So she had all types of stigma. And this is a model that I found in one of the articles, a very nice model, that looked how she had the internalized stigma, and she had experienced both of them led to the anticipated stigma. She felt she would not be handled adequately, and for this reason, she did not go to the healthcare system. Had she gone to the healthcare system, she would have a better quality of life. But that's why she had an anticipated stigma that left her away from medical care. This is another case, I just pass on it. It is a 14-year-old girl presented to OPD, a year outpatient department, a year after being diagnosed with diabetes and refusing insulin treatment. A urine analysis was done and it showed ketonuria and a high HbA1c, which speaks for a very high sugar in her blood, very dangerous level. The parents were counseled about diabetes and the need for insulin and admission to the hospital. The father refused admission because, I'll talk later, because she will be labeled diabetic. Later that year, we hear that the daughter succumbed a severe infection and she died in another hospital. Social and lifestyle factors. Type 1, the daughter had type 1 diabetes, and this is to the family is a social stigma, especially for girls. So the father was saying that his daughter, if the society knows that she has diabetes and she's taking insulin, she will not marry. Many parents try to hide their daughter's illness. Effectiveness of insulin therapy is compromised. Even the family had some feelings, anxious feelings, anxiety, and bad feelings of blame. And they mentioned more than one time that diabetes is a barrier in social relationships such as divorce, infertility, and sexual problems. And studies have shown in a survey of 5,000 5,000 diabetic patients, type 1 and type 2. Type 1 comes to the young, type 2 comes to the older. They found that 75% of patients feel stigmatized, and 85% of the parents of these diabetics, they feel blame somewhere. And the more the treatment is visible, if they are treated by a pump or insulin, something visible, the more the stigma is strong. So what are the strategies to decrease stigma? There are more than one strategy: intrapersonal level, interpersonal level, institutional and organizational level, and community. The intrapersonal level, for the patient herself, treat her, counsel her. For example, for Lina, just to tell her that there are studies that we can do for you to support her, to treat her depression, and some go into cognitive behavioral therapy, which is a type of therapy structured approach in which patients are trained to identify and modify negative beliefs and negative interpretations, to empower her, stay beside her, and to help her with advocacy and support groups. And in support groups, sometimes the patient's reaction to their problems improve, misconceptions on certain treatments is reduced, and the social isolation improves. So we have to work on the person at the personal level. Interpersonal level is an intervention that aims at modifying the affected person's environment, the family, the support system around the patient, and deal with the impact of social support and social networks. For example, to care, to support, to be open, to disclose. Like in our case, she refused to disclose because, as she told me, I will be killed and they will not believe that I was raped. For example, patients who have HIV, they send them teams, home care teams to their houses, just to show the family that these persons the medical team are coming and taking care, so it's not dangerous to support them and help them. And community-based rehabilitation, it's where we give them rehabilitation, equalization of opportunities, and social integration. And we also need to work at the community and the organizational level, which is at the organizational level is the intervention. It aims to modify the health and the stigma-related issues. For example, in my case, in Lina's case, aspects of an organization. Do you have a policy about confidentiality? She was asking questions related to the organization. Like she would say, doctor, you are writing my note, where are you writing it? If the nurse goes in, will she see my note? Are you going to write that I'm raped? So is there a policy that protects me? So these are all organizational issues that should be tackled also. And the training programs, training to the healthcare workers, because also studies have shown sometimes the healthcare workers have negative attitudes towards certain diseases. Like for the HIV, they would blame a patient who has an HIV, just to train them that these, not to be judgmental, on the other hand, to be supportive and helpful to the person. And at the community level is that the intervention at the community level aims to increase knowledge regarding specific issues, educating more and more. It can be during contact, like what happens in the media when they bring, for example, an HIV person, and they talk to him and about the suffering, but this should be coupled with education, otherwise it gives negative connotation. And to be advocate for the persons who are stigmatized, whoever they are, HIV, women, or whoever. Thank you.
Thank you, Dr. Sharafi, for these interesting cases and the conclusion. I would like to invite Dr. Ghada Khouri. Dr. Khouri, she is a clinical assistant professor at the Lebanese University at the School of Pharmacy, and she is a pharmacist pursuing further studies in public health. And she'll be talking about knowledge, attitudes, and practices regarding family planning methods. Dr. Khouri, how many minutes you want?
Hi everybody, thank you Dr. Kak, and I appreciate the attendance. I know it's Friday, it's 4 and it's an almost sunny Friday, promising weekend, I'll be short. Background, family planning, and I'm gonna read the definition based on the WHO. It's basically allowing individuals or couples to anticipate and attain their desired number of children, and it also takes into account spacing and timing of the birth. It's achieved by relatively simple measures, which is contraception. Why is it important and how come it's part of today's conference? It's basically because by family planning, we are empowering women, we are allowing women to further pursue their education, their career, to have roles in the society as well as roles in the economies that we've been hearing about, all of the discrimination specifically in Lebanon. Worldwide, we see that 1 in 3 women does not have access or that has difficulty accessing contraception due to various predictors or various factors. What do we know about Lebanon? We know that in 1998, the government put in place and implemented a reproductive health program together with the United Nations Population Fund. The objective was to give access to quality services and to sustainable reproductive health services, including family planning and sexual health. Today we're going to focus on family planning as part of our study. Since then, what do we know? I looked the literature and I did some extensive literature search, and I wasn't able to find any recent national prevalence rates of contraception use or any assessment of the services that were implemented back in 1998 that were done on the national level. And I have listed here for you some of the studies. Dr. Kak can attest and give you more insight on that if he finds anything missing, which I doubt, right? Okay, so the latest report we have dates back to 2004. And the prevalence of contraception use among women was equivalent to 56%. In 1971, we had a prevalence of 53%, so we see that it's a pretty stagnant percentage, and I'll give you also in a minute our findings, and you'll see that you might be disappointed since this percentage is not going to be increased much. So in light of this case evidence, we decided to conduct a study on the national level to get prevalence rates of contraception use in 2017, so 10 years almost from our last evidence. And we also wanted to assess the barriers that are, and not women are not having access to those contraception method because of those barriers. We did a cross-sectional survey, which is a typical study design for such a topic. We made sure we included women from all sorts, from all regions, and according to, we weighted the sampling according to the mostly populated governorate, which is Mount Lebanon, Beirut, Bekaa, North and South, to have a representative sample. Based on our calculations, we ended up estimating a total needed sample of 800 to reach our power of 80%. The data collection process, we did a household survey. We went in after taking verbal consent and making sure people were okay with our interview survey. We recorded the information and made sure it remained anonymous. The instrument we used was not something we came up with. We used a standardized form or a survey that's called the DHS, the Demographic and Health Survey, which is developed and implemented usually by the USAID. It's used typically to get fertility measures and to measure attitudes and knowledge for family planning topics. The questionnaire had two components, the social demographics as well as the objectives that we were aiming at, which was the contraceptive use and attitudes. Data was analyzed. I'm not going to go and bore you with that, but we made sure that we used appropriate tests depending on the nature of the data that we were obtaining. We enrolled 825, 437 were women, so we met our study power. Those are some demographics. We made sure that the different religions were well represented. Education was mostly to the secondary level, and the mean household income was around $1,000 per month. When we examined the healthcare seeking, we found out that the male was the head of the household in the big majority of our patients, and that reflects the patriarchal society of Lebanon. We found that women had some autonomy since they were seeking reproductive health services by their own in around 44% of the times, and the husband was only involved and accompanying the wife to reproductive health services in only 30%, and that can be explained to the nature or the topic of reproductive health or family planning that is sometimes considered a female topic, and men don't have a lot of influence or knowledge, and maybe sometimes are reluctant to take part in such health-seeking behavior. When we asked couples about whether they discussed family planning among themselves, we had around 1/3 saying no, so around 31% of the couples did not have such open discussion, and the main reason, as you can see, was 60% of the time women being afraid or uncomfortable discussing such situation. The religious reasons came next, and people considered that it's up to God and they don't have to plan their family. When we assessed knowledge, we scored very well, or people scored very well. Everybody was well aware of the presence of modern contraception techniques like condoms, pills, intrauterine devices. So the problem is not that they don't know. They know very well, and the most important source of information remains physicians. So here the healthcare providers, physicians, play a very important role in disseminating messages regarding family planning and reproductive and sexual health. They also reported having a good access to family planning methods, so that's not the problem. So people knew well and had access to all sorts of modern contraception. They also had favorable attitudes, so they considered that it's okay for a couple in 70% of the cases to use family planning contraception, and we see here that the traditional method, meaning withdrawal or periodic abstinence, were preferred over the modern family planning methods. Now here comes the objective. Our calculations revealed contraception use equivalent to 55.6%, so we're not doing much progress. And back in 1971 we had a rate of 53, in 2004 we have a rate of around 55.5, 10 years later we're stagnating at 55.6. When we looked at the predictors, religion appeared to have a very important role, as well as educational levels. So people that were more educated were using more contraception. So if we want to target groups, it will have to be those people with lower educational level, as well as lower age, and as well as a religious group other than Christians, since we're seeing here 3 times more use among Christians. When we looked at utilization trends, we still see periodic abstinence, which is a traditional non-effective or less effective method being used, and this is something we'll have to deal with. Factors affecting the choice, it's always effectiveness, so people look for effective method. Despite looking for effective methods, they're still using periodic abstinence, which was proven to be not that effective. So that's very important in terms of designing awareness and focusing on advocating for modern family planning methods. Always private sector being the majority of where people get their services from, and that reflects the highly privatized Lebanese healthcare system. Among non-users, we see that fear or concerns about safety was the most common reason for not using that, as well as religion, and that's typical in our Lebanese system that's ruled, if I want to say, by religion. We calculated unmet needs according to the revised definition, and it turned out to be 11.4. That's an acceptable number. However, we can do more, and we're estimating that to be even higher due to the nature of the survey. People that had higher unmet needs were lower age groups, lower educational groups, as well as Islam. We had more people that had unmet needs. So again, religion plays a very important role in this issue. When we asked people to evaluate the available services, it ranked around 3, so it's an okay, but we can do much better in terms of improving those services. We have to keep in mind that we have some limitations. It's a study that's based on survey, so response bias, people might not have been very honest, people might have underreported their use or overreported their use because of social pressure. We have excluded non-married, sexually active people that also can affect our results. We did not take into account after morning pills as a measure for contraception, nor we did tackle the abortion. That's a highly controversial problem or highly controversial topic in Lebanon. I still believe that despite the limitation, we did a good job by giving current estimate of how family planning is doing in Lebanon. We also set the ground for any future research that might be put in place that entails the empowerment of women through the access and utilization of family planning services. To end, I want to say that by that, the clinical implication at this point in time would be to ensure everybody has universal access to sexual and reproductive health to meet the WHO Sustainable Development Goal by 2013. And that would be equity in healthcare services. And what we'll be doing is looking at each governorate and seeing which region has the least access, so can ensure equity. Number 2 is quality, ensuring quality, and that can only be done through continuous monitoring. We cannot wait another 10 years before evaluating the family planning services. A national family planning reporting system needs to be in place in order to ensure quality. And last, protecting against financial hardship, and this is very important in Lebanon, due to the privatized healthcare system that many times put our patients into financial hardship due to the lack of public services, or at least due to the lack of trust of public services. With that, I'm going to end, and thank you again for being here.
Thank you for taking 5 minutes plus 6 minutes. It's okay. Thank you for this update on the use of family planning, which is true still at ELAL over the past 20 years. Our last but not least, this I usually say is last but not least, is Nadia Badran. Ms. Badran is a good old friend, and Badran is very known nationwide for her work in HIV/AIDS. But apparently lately she shifted. And she's a program coordinator and knowledge hub manager at the famous also SIDC. And Nadia will be talking about health workers or social workers and stigma. And she told me today that she is the president of the syndicate of the social workers. The syndicate has been there for 20 years also. So تحياتنا للسوشيال workers. And also you have 10 minutes. Your presentation.
First, I would like to thank you all for this opportunity, for this project, KIP, for all the funders and supporters of this conference. So I will be talking about a research that we did at SIDC. It's about social workers' perceptions and attitudes towards LGBT community in the Lebanese context. And I would like to mention first that this study was not we were not being able to do it or to succeed in it without the big implication and support from Hala Najm, that it is MPH, so master's public health from AUB, and she is now working at SIDC. So thank you very much, Hala, and I would like also to thank a lot Dr. Huwaida Matta Abel Buramia, that she is a doctor and associate professor at the social work school at St. Joseph University. So thank you also a lot for your guidance and for your support and for your support for this study. So why SIDC and why this kind of study? First, because SIDC, that we were working a lot about HIV/AIDS, about with LGBT community and other vulnerable group, and in our vision, it's to work on Lebanese work in the Lebanese community to be free from stigma and discrimination, and where key population, among which LGBT community, will be able to fulfill their human rights. So, and our mission at SIDC also to improve the quality of services for these groups through provision direct services for them like harm reduction and other kind of healthcare services in the field of HIV, drug use, etc., and sexual health, and to do a lot of advocacy, networking, and partnership, and to do also capacity building for NGOs at national and regional level. And why we choose this kind of study in particular, because all we know, and it was very obvious from all the panelists as well, that the social environment in the Lebanese context influence a lot the LGBT needs and their access to quality of services, including social services, not only health services. And because we know that there is a lack in the academic preparation of these social workers to be able to serve these population. So what was the aim of this study? It was to learn more how do social workers perceive LGBT community. So we wanted to understand their perception. We wanted to understand as well their attitudes toward this group, and we wanted to understand their readiness to work and to intervene properly with these groups. These are the three major objectives of our study. How we did our study? We adopted the qualitative methodology, and what we did is in-depth interview. So we interviewed from 6 representatives of the 6 universities in Lebanon that teach social work. We succeed to do the interviews with 4 of them. The 2 others presented as excuses. They didn't want to share with us their to be part of this study. And we did also in-depth interview with 16 social workers, and we tried to choose social workers that had 3 years minimum of experience in the social work field in general, and if some of them would have the experience working with LGBT and others might not have. So these were the inclusion and exclusion criteria for us. And we adopted also the snowball technique. So we were asking the social worker to give us number of another social worker as well. What were our findings? So our findings will be divided into major packages. The first one is the findings at the university level, and the second one at the level of the social workers themselves. So at the level of universities, when we interviewed the university directors, all of them said that at university they have a non-discriminatory approach, and it's towards everyone, not only LGBT, it's for everyone. And the essential point for them is how to prepare their students with a package of values, with a package of principles that is very important for them to be able to work with everybody. So with every individual or beneficiary, they might intervene with this person sometime in their profession. Also, the university representative said that there is no courses specific, or there is lack of courses specific in the curriculum that tackle this topic. And they talk also about the cultural and religiosity that play an important role in determining the degree to which students accept such topics. Even though the university were from or have different cultural and religious background, but all of them said that at universities there is no discriminatory, but they mention it is related to the students, the proper culture of their students themselves. And this is what we will be talking next about. And some of the challenges, they said the curriculum of the social worker is already overwhelmed, so we cannot do more for the curriculum, and the possible lack of competence of instructor. So if we integrate some topics, but we need teachers to be able to talk about this topic and to be able to discuss this kind of topic. What were the findings at the social workers level? At the social worker levels, we have different levels as well. So at the level of the perceptions, the participants, all of them said that LGBT are individuals, are human beings like any other person, and we all, as their attitude that they said, it was divided the attitude into two levels. At the professional level, all of them said we are ready to work with everybody, and because we have the ethics and we have all these principles and values that were taught at the university, so all of us are very well equipped to deal with everyone without any discrimination. But when it comes to personal level, here also we can see that the cultural and religious background of the social worker themselves, it play a big role, and here also it will be the same what the university director were saying. And findings also at the social worker level, but at the level of the competencies and abilities to work with these people, they said that we don't have training at university to be able to work with these people. This is why sometimes we feel that we are incompetent to work with, and some of them said that we had a lot of skills at universities, and we are able to start to work with everybody. And for the readiness of the people, it was like we have the personal conviction to work with these groups and the work experience. And when the people have a working experience with the group, they learn how to better work and intervene with this group. What are the recommendations? Our recommendation will be divided onto three levels. The first level, it is related directly to the social worker himself or herself. So as a social worker, so we look at the social work curriculum. So one of the recommendations is to, for example, to organize thematic workshop at the university for students to do this kind of discussion with them about LGBT, sexual minorities, etc. Or to integrate units, for example, about this into courses or outside courses, and to invite, for example, social workers who have this kind of experience from the field to come to the university and to talk to other social workers as well, and to integrate maybe in the practicum courses related to these groups. As for university level, we thought that at university level we should work with two hierarchy. The first one is with the social work department directly, and where we can discuss the possible and the potential if we can integrate in the curriculum some courses related to sexual minorities, or to integrate it into some other courses related to human rights. And also there is a very important point to hold workshops also for teachers to be able to talk also about their own perception about this groups. And at the higher level management, for example, to highlight the importance of accepting these groups and in different occasions, for example, to give speeches about human rights, etc. And if needed, to integrate something into the policies at the university to for the teachers and students and staff, and to create platform, etc. And our last recommendation, and I will finish by this. So at the higher level of recommendation, it is at national level. But here also at the national level, we have two sub-levels. One level, it is related to social work profession in Lebanon. So maybe we will need to advocate for a law to regulate the social work. So, and in that case, we can give sanctions, for example, between two brackets. We can do more audit on the work of the social workers. and to ask, for example, the social work syndicate to important to integrate this kind of work in their action plan. And at a higher level, we have to work on the environment in Lebanon to create more platform, more campaigns with some ministries, Ministry of Health, Ministry of Social Affairs, to fight stigma and discrimination. And at the last recommendation will be to talk more how we can advocate for the elimination of the Article 534 that was introduced before and that prohibits having sexual relations that into practice contradict the laws of nature. So this was our study and these were our recommendations, and thank you.
Amazing panelists who walk us through discrimination, whether in healthcare, whether in perception of the provider, whether in accessing knowledge or other services, also in relation to other colleagues involved in healthcare provision. So we'll have probably maximum of 10 minutes, 8 minutes of questions. I would appreciate if we can have short questions and shorter answers.
For family planning.
Dr. Khouri.
Dr. Khouri, about the contraceptives and family planning. She mentioned about sometimes the woman came alone. I would like to know these percentage of women came alone with the knowledge and consent of their husbands, or they came just behind their backs, because sometimes the women have no say in what they want to use. And I know some people who used contraceptives, but their husbands died and they never knew about it.
Interesting. Dr. Khouri.
Challenges getting the real answers. So the answer I'm going to give might not be, the reflecting the reality. The people that came alone, as per their reply, came alone because their husbands were busy or they were at work. So with the consent of their husbands, they were coming to clinics. Or the other reasons they gave is because they felt that husbands were not, interested, or that specific topic of family planning was only related to them and not to the couple as husband and wife.
Okay, thank you. Next question. Yes.
I witnessed any specific area of healthcare where there is stigma on the gender. So, for example, psychological healthcare, where you could see less men because it's not agreeing with the traditional gender role. Do you see what I mean?
You mean in general, the diseases that I mentioned are the most top on the list in stigma. But yes, sometimes we encounter some cases that are related to gender. Yes, we encounter this.
In which specific?
We do, for example, the case that I presented, diabetes being a female put more burden on the family, while if you were a male, this would not have come up. Okay, for example, in thalassemia, we have a lot of females who are carriers of thalassemia. They only carry it for their kids, and all they have to do in the future counsel their kids that they should not marry people, partners who carry the trait, and it's not does not have affect their health. When they come to premarital assessment, we do premarital. They do some tests before marriage. When the male knows that the female has a trait, it's stigmatized, and sometimes we do education and counseling session to educate the partner that it has no effect on the health of your kids except.
Okay.
Okay.
Thanks. Of course, also you see more women in psychiatric clinics and weight management clinics. You see less men in these places. So it's probably across the board, local and globally, in regards to male, female, the biological identity. Third question? Yes.
Here. Dr. Abou Zaki from Marsa, you were speaking on men who have sex with men. I was wondering if you could tell us also about the situation of lesbian women or transgender people And the second question, if you could tell us, any one of you, on the availability and accessibility of treatment of HIV-positive people.
Okay, sure. At Marsa, Center for Sexual Health, even though we advertise our services for everyone and they're available and accessible to everyone in the community, we find a huge disparity when it comes to who actually comes to the center. So the majority are actually men, regardless of their sexual practices. So the majority of people who come to Marsa are men. Your question was about, are you asking specifically, is there anything specific that you would like to know about women who have sex with women? We have actually one of our studies, we assessed contraception use among women in general, and we found that there is very low correlation, actually there's a high correlation between knowledge and condom use, and there's very low agency among women in condom use when it comes to contraception. So, I mean, I guess a large amount of them believe that it is not necessarily their decision when to use a condom, for example, but it's their partners. That's specific for women. We have, of course, acknowledged a number of issues regarding transgender individuals. We have a lot of information about transgender health because it's a very not talked about topic in Lebanon. So we made sure to provide a lot of information that's accessible on our website. We also have a video about it. Anyone can learn more about transgender health. Your second question? Was
HIV/AIDS treatment. It's available for free in Lebanon.
Yes, all our HIV positive patients can get the medication free of charge from the Ministry of Health. On one condition is that we have to declare to the Ministry of Health about their names, but this is done through very confidential messages between us and the Ministry of Health. Even we don't send emails or anything of this sort. We just hard copies to very specific persons so that to ensure confidentiality. If they do not accept to declare to the Ministry of Health, they cannot take the drug free of charge.
I've been told this is the last comment from Ms. Badran, and we have to leave the room. The panelists, not everybody. You stay, we leave.
Okay, only to answer about HIV and people living with HIV. Yes, there are many services for them, so they can benefit from social and healthcare services and counseling, individual or group counseling, and also for the medication. It is available for free for all Lebanese, non-Lebanese, such Syrians or Palestinians, and it's free from the Ministry of Health. For the confidentiality, it is confidential, like to declare themselves to AIDS infectious disease, and the infectious disease refer them to the Ministry of Health to get their medication, and it is confidential the whole process. So there is no, it's not discriminatory or we.
Can we take one last question?
أود أن أشكر الأستاذ.
طبيعية بالبانل.
لا منيح أنا سمعت شيء إنه طبيعي منيح. أنا
ترجمة لك بس لا نسف أحد من الموجودين المثاليين.
مش هذا موضوع النقاش، أنا بس علق لو سمحت. لو سمحت. إذا كانت الطبيعة قد زودت المتغيرين جنسيا الهيتروسكسوال بأدوات يمارسون بها تغيرهم الجنسي، فما هي الأدوات التي زودت بها الطبيعة المتماثلين جنسيا لهوموسيكسوال ليمارسوا تماثلهم الجنسي؟ أسألهم ما هي الأدوات التي زودت بها الطبيعة كما زودت المتغيرين جنسيا، يتفضلوا يقدموا لهذه الأدوات. شكرا. هي أمر غير طبيعي.
لا هو شكرا على سؤالك. سؤالك موجه لحدا من المنتدين؟
أنا قلت أن أحب أن أسمع، وأنتم أطباء يجب أن تقولوا كلمتكم بشجاعة وتشهدوا عليها في هذا العصر. كما شهد عليها قدماؤنا بأنها شاذة. لماذا نحن نتنكر لما قال به آباؤنا وأجدادنا وعلماؤنا وفلاسفتنا
سيد حسن
بأن اللواط أمر شاذ؟ لماذا يأتي، مش أنتم عمول، يأتي من يقول أنها أمر طبيعي؟ وألغيت الندوة في الجامعة الأمريكية يوم الخميس الماضي فاصلة لأنه ما بدهم يسمعوا كلام ما بيعجبهم.
شكرا على سؤالك. سوري. اهلا وسهلا فيك. بس السؤال هو سيد حسن، انا طبيب كمان حجاوبك استاذ حسن. بعزم العدمات الجنسي ليس فقط بما منحه الطبيعه للاعضاء، بل بالوظيفه والاوتكم والتوقعات. اوكي، هناك وظائف انجابيه ووظائف بالمتعه، وهناك خيارات جنسيه ليس لها اي جذور مرضيه او شاذه او غير طبيعيه. فالموضوع ما بالاساس الطرح لا يجوز، لانه ما في حالات شواذ او حاله مرض او غير ذلك. بتمنى عليك اذا بدك نكمل بعدين النقاش برا، لانه حتبلش جلسه هلا. شكرا كثير، شكرا لك واهلا وسهلا فيك.